Dr. Ram, have Dr. Ram with us today. And Dr. Ram doesn't need really any introduction, but he's well-known neonatologist, and he's currently serving as a director of the neonatology at Cedars-Sinai Guerin Children's Hospital. Dr. Ram already has pioneering work in non-invasive ventilation, and I think most of us has seen him probably speaking about the Ram cannula and many other things that he's interested in. So it's our pleasure to have you here today in Winnipeg virtually, and thanks a lot for responding to our invitation. The floor is yours, Dr. Ram.
Thank you so much for your kind introduction. And also thank you for the invitation to talk about another topic that I've been working with from 1980s, surfactant therapy. And I was given these challenges, controversies, and current advances. I think in spite of over 40 years of research, we still have a lot of challenges and controversies about, specifically when do we give surfactant to, which babies should we be giving it, and what type of a surfactant is pretty much settled as of now. I know in Canada, I use a lot of Bless Canadian surfactants. I'll show you some data published by Canadian investigators and current advances in surfactant therapy. So these are my disclosures. I've been a consultant or in the Speakers Bureau, or I've received multiple grants from many of these companies. Burroughs Wellcome, which was the original ExoSurf studies when I was involved as a junior faculty, KC USA, AbbVie, Mead Johnson, Icaria, CareFusion, Mallinckrodt, and Neotech Product Sync. So I do a lot of industry-sponsored studies, both device and drugs. If I receive any honorarium, I donate all of that to charities to help mothers, newborns, and children globally. I have no equities or stock options in any of the companies. I do not receive any royalty payments from either KC USA or any other surfactant manufacturer in the world. So the challenges and controversies are, what is the type of surfactant? Should be used from bovine or porcine? Second, dose. Should we use 100 milligram or 200 milligram per kilo? Third controversy is, should we give it early to all babies with preterm babies with RDS or babies at risk for RDS, or rescue them once you make a diagnosis of RDS, either by clinical scoring or lung ultrasound is becoming commonly used in many centers, or the third is late surfactant for evolving BPD. And then the other controversy is sedation. Should we give sedation to these babies? Again, there's no consistency on whether we should use what drugs to use if we're going to use sedation, and surfactant for neonatal ARDS and evolving BPD, as I mentioned, and then what happens in babies with pulmonary hemorrhage. There are some people who believe that surfactant therapy causes pulmonary hemorrhage, and I do not believe that's the right answer. It's related to pulmonary overcirculation, often related to PDA with a huge left to right shunt, hemorrhagic pulmonary edema rather than true pulmonary hemorrhage. And there are studies, observation studies, case reports of giving surfactant to pulmonary hemorrhage. Current advances, basically techniques of surfactant administration. We have changed from routine intubation by endotracheal tube giving surfactant and keeping the baby on a ventilator to intubation surfactant extubation. Recently, they talked about INREXURE, which is intubate, recruit the lung, putting a high-frequency oscillatory ventilation, surf the baby, and then extubate them. I do not believe that's a non-invasive or less invasive surfactant administration technique, or LISA. And then LMA, laryngeal mask airway, or supraglottic airway surfactant administration, or SALSA technique. Nebulization, I do not think it's going to be working. We have been working on nebulized surfactant for a number of years. It does work in babies over 29 weeks. But the number of times babies need surfactant in over 29 or 30 weeks is not that many. Majority of the babies that we want to give surfactant is micropreemies or very preterm babies. And there are some studies looking at lung ultrasound to predict the need for surfactant treatment. And finally, surfactant in combination with steroid, budesonide. As we all know, BPD is an inflammatory lung disease. If you can downregulate the inflammation early on, maybe we don't have to use postnatal dexamethasone and other toxic drugs. Unfortunately, it did not make a difference in a larger study it'll be published very soon. I'll show you data that was presented by Brett Manley from Australia in the PAS meetings in Toronto. So when you look at what type of a surfactant to use, we have surfactant from porcine lung or bovine lung. Those are the two sources we use in the US and Canada and other parts of the world. There are some centers that use goat lung surfactant, but there's not much data on that. So if you look at the porcine surfactant, poractant alpha or Kirosurf, it comes from minced porcine lung. It undergoes an additional step called liquid gel chromatography. Therefore, you get a pure form of phospholipids, polar lipids. So it has the highest amount of phospholipids, 76 milligrams per ml. Disaturated phosphatidylcholine, or DSPC, is the most important phospholipid. That's about 30 milligrams per ml. If you look at the proteins, surfactant-associated proteins, we are all interested in surfactant protein B, which is very crucial for surfactant function, is 0.45 milligrams per ml. For a number of years, we didn't know that plasmalogens existed in surfactant that we make or animals make, mammalians make. Plasmalogens are a very good antioxidant phospholipid. It has been studied in neurovascular and in cardiac adult patients, but not in neonatology. It protects endothelium cells, it protects against stroke, and it's an antioxidant phospholipid. So plasmalogens having that is also not a bad idea. Surfactant comes from minced bovine lung extract, and then you have to add additional DPPC, dipalmityl phosphatidylcholine, more palmitic acid and tripalmitin are added to that, and then you get 25 milligrams of phospholipid. DSPC, disaturated phosphatidylcholine, somewhere between 11 to 15. We really don't know how much SPB is there in the package insert. Plasmalogen is about 1.5 moles %. Infosurf or cofactant is the third surfactant used in the US. And it's a lung lavage rather than minced lung. So it has higher amount of phospholipid, a little bit of cholesterol in it. They do have to add some more DPPC. So 35 milligrams, out of that, half of that, nearly 16, is disaturated phosphatidylcholine. SPB is 0.26, and plasmalogen not specified. You are all familiar with bovine lipid extract surfactant, Bless, from Canada. So it's a bovine lung lavage. It has 27 milligrams of phospholipid. They don't know how much of that is disaturated. And proteins range from 0.176 to 0.5. And neither SPB nor plasmalogen amount is specified in the package, and so really don't know how much it contains out of the 0.5 milligrams of total protein that are surfactant associated. So there are major biochemical differences between these surfactants that are available globally. The question is, does it make a difference? There are many studies, both in Europe and the US, comparing poractant alpha, porcine versus bovine surfactant, biractant or Surfactant. From 1995 through 2011, we published one of the largest trials in 2004 from US multi-center trial. Again, 750 to 1750 grams. All of them are rescue treatment, not prophylactic treatment. And just like our study, other studies have shown, if you use poractant alpha, you lower FiO2, faster weaning, decreased mortality, less days on mechanical ventilation. So it appears that minced poractant alpha, porcine surfactant is better than biractant or Surfactant. So this was a systematic review, Cochrane review, published in more than almost 10 years ago. There are significant differences in the clinical outcome between Surfactant and Kirosurf, including a significant increased risk of mortality before discharge, death or BPD is a composite outcome, PDA requiring treatment, and number of babies receiving more than one dose of surfactant in babies treated with Surfactant compared to Kirosurf. Most important point in this systematic review is a higher initial dose. If you use the same dose, 100 milligram per kilo, your effects are broadly equal, whether you use Kirosurf or Surfactant. There was another systematic review in 2019, looking at 14 trials over nearly 1,500 babies, looking at higher dose versus lower any dose. All of them are using poractant alpha. compared to Surfactant or Alveofact, which is a surfactant available in Germany and some European countries. They showed that if you use 200 milligram per kilo, both BPD or BPDR mortality were significantly lower. So better outcomes clearly with a higher dose of poractant alpha for the first dose. This is by Daniel Di Luca from Paris. So Canadian Pediatric Society made a statement. It is Fetus and Newborn Committee in 2021. I have not seen an updated statement from Dr. Shah and others. In summary, animal-derived and the newer generation synthetic surfactants are both effective for treating RDS and improving survival without BPD. We really do not have any new synthetic surfactant available right now in the market. We just published a paper on CHF 5633, which included a synthetic surfactant with surfactant SPB mini peptide. And in that study, it was comparing poractant alpha. It was equally effective. However, we do not have commercially available synthetic surfactant. So when comparing different animal-derived surfactants, evidence suggests that porcine minced lung extract, poractant alpha, especially in higher dose, may be superior to bovine surfactant for improving RDS and reducing mortality or BPD in babies with RDS. Again, level 1A evidence. But this was in 2021. Lemry et al. From Canada did a pragmatic trial, a cohort study published in 2022. Their objective is to compare the short-term respiratory outcome, comparing babies that were treated with BLESS versus poractant alpha. It's in 13 centers. I'm sure some of you might have participated in this study. Each center provided BLESS for a set period of time and then switched to poractant alpha for the rest of the year. So the primary outcome was total duration of respiratory support. Nearly 1,000 babies were enrolled. Mean birth weight is about 1 kilo. Mean gestational age 27.1 week. So nearly half of them got BLESS, half of them got poractant alpha. They did not find any difference in the total duration of invasive mechanical ventilation or non-invasive support. Median was 38 to 40 days. Need for redosing, BPD, or survival to discharge or length of admission. So basically, in the pragmatic study, they did not find any difference in short-term outcomes between the groups based on the type of surfactant received. Again, this is a cohort study, not a randomized controlled trial. Now, okay, you decide to give a surfactant to baby. The question is, when do we give it? And should we use a higher initial dose? I already mentioned some of the data. I'll show you some more studies. And FiO2 threshold, this is a point of contention and controversy. Should I give surfactant to babies in 30% oxygen or 40% oxygen, right? So let's look at some data. Optimizing CPAP pressure, obviously, recruiting the lung before you give surfactant probably will give you better results. And clinical decision thresholds based on FiO2 or arterial to alveolar PaO2. Most of us do not wait for a blood gas to decide about giving surfactant. But in the surfactant placebo trials, we have to have AAPO2 less than 0.22 to randomize babies. So, but nowadays, majority of the centers, I don't believe, will wait for a blood gas value, PaO2, to decide about whether to give surfactant or not. There are a number of studies using respiratory distress scoring, clinical scoring, like Down scoring, and lung ultrasound scores. And choosing the method is less invasive technique, namely LISA. So here is looking at risk factors that ended up having failures. This was from Netherlands. They looked at what happens, why do babies fail missed? Minimally invasive surfactant treatment, basically same as LISA in 185 babies. They showed that if you use a lower surfactant initial dose and the mothers did not get antenatal corticosteroids, both are obviously modifiable. So you try to encourage the moms to get antenatal corticosteroids when they come in preterm labor, and then using the MIST technique, if you use a higher dose, it appears to be better. So here is the data, looking at surfactant dose, less than 200 milligram per kilo, MIST failure, need for early mechanical ventilation. That was the definition of MIST failure. In MIST success, if you use a higher dose, success is better. MIST failures are higher if you use a lower dose. No antenatal corticosteroids, again, LISA or missed failures are higher, almost double. In CRP, more than 10 milligrams per liter. This is to suggest that baby may have a congenital pneumonia, an infection, not a simple RDS. Again, if you use a higher dose, you get better outcome, even in babies with complicated RDS/pneumonia. Oxygen before missed, higher FiO2, failures are higher. IVH grade 2 or greater is also higher in babies that failed missed or minimally invasive surfactant treatment. Days on mechanical ventilation is also higher. So survival without any serious adverse events were better, 76%, if you used a higher dose, initial dose. So as you can see, missed failure with 200 milligram per kilo dose was 14% compared to 35% if the dose of first dose was less than 200 milligram per kilo dose. We also published a paper in 2012, more than 12 years now. We were using at that time Insure, and then when we did Insure, we randomized them to CPAP or Insure plus NIPPV. Using 200 milligram per kilo Surfactant alpha, 110 babies from 5 centers in the US, extubation failures, physiological BPD, or oxygen at 36 weeks post-menstrual age, or need for a second dose of surfactant. These 3 parameters were statistically significantly lower if you give surfactant to a baby with RDS and then manage them post-surfactant with NIPPV. We pretty much is our primary mode of respiratory support in preterm babies, NIPPV. The baby doesn't need it, then we transfer the baby to CPAP. So there have been 8 randomized controls have been published. Kugelman from Israel, Bandari from Philadelphia, and our own trial I just showed you. When you do combine Insure with NIPPV, your failure rates are much lower compared to Insure and CPAP. This is CPAP, surfactant, post-surfactant CPAP. Failure rates with Keith Barrington when he was in San Diego was 56%. Kala from Philadelphia, 53% failures compared to 35 or 44%. So you're combining a non-invasive respiratory support like NIPPV with surfactant, you get much better results. So here is a paper from Ancona, Italy, Virgilio Cornielli, who's done a lot of surfactant kinetic studies for a number of years. In his own unit, he looked at before he started switching to 200 milligram per kilo dose compared to 100 milligram per kilo dose. So he showed that after the switch in their unit, is an observation study, 658 preterm babies less than 32 weeks gestation, mean birth weight about 1 kilo. And they showed that need for mechanical ventilation was significantly lower. CPAP failures hours were also lower. So they recommended that if you're going to use in the preterm babies, use of higher dose is better. Again, when they looked at retreatment before and after switching from 100 to 200 milligram per kilo, redosing was 17% for a second or a third dose compared to 47% when they were using a single dose, 100 milligram per kilo dose. BPD also was lower, 18.7 compared to 27.3. So they had less days on oxygen and mechanical ventilation in BPD in babies less than 32 weeks gestation in their NICU. The next question is, what FiO2 should we be using? 30, 40, 50%? So there are 3 large observation studies. None of them are randomized controlled trial observation studies, retrospective studies. Looking at, this is from Peter Dargewell from Australasia, 25 to 30 week gestation, initially managed on CPAP. He looked at predictors, gestational age, birth weight, multiple gestation or not, mode of delivery, FiO2 at 2 hours and 6 hours, and the level of CPAP. Both in babies between 25 to 28 weeks or 29 to 30 weeks, FiO2 of 30% or greater in the second hour of life was identified as a key predictor of CPAP failure, both in smaller babies and in more mature babies. Area under the curve, 0.83 or 0.81 in more mature babies. 297 babies. The second paper from Poland in 2019 looked at 389 babies, less than 30 week gestation. CPAP was started within 15 minutes, no mechanical ventilation in the delivery room, and surfactant was given per European guidelines those days. So they looked at gender, gestational age, birth weight, antenatal corticosteroid use, mode of delivery, level of CPAP and FiO2 in 1 hour and 2 hours. Again, very similar to Peter Dargul's study. They also came up with the same conclusion. FiO2 in the second hour of life is a significant predictor of CPAP failure with a prognostic cutoff of almost close to what Peter Dargul published, 0.29 or 0.3. The sensitivity of 73%, specificity of 57, area under the curve, 0.7, p-value less than 0.0001. So clearly, a 30% cutoff in these babies may be a good predictor. It may be a good indicator to give surfactant to babies. A third study, Venkat Kakilaya from Dallas, Texas, again looked at similar things, 284 patients. Now he included even smaller babies, 23 to 29 week gestation over a 5-year period, requiring CPAP in the delivery room, not intubate in the delivery room, looked at multiple factors in modeling and validation cohort. And he showed that AAPAO2, arterial to alveolar PaO2, less than 0.22, which is pretty high. FiO2 these babies will require. Maximum FiO2 0.3 within the second hour of life. Or if you had a chest X-ray, they had a scoring system, severe RDS. So of these three predictors, only the maximum FiO2 and chest X-ray scoring were found to be significant in using the validation cohort, with FiO2 being the key driver for CPAP failure. So there are area under the curve 0.81. So there are three large observation studies from 3 different parts of the world that suggest that if the babies on preterm babies less than 30 weeks or 32 weeks on oxygen, on CPAP, and requires 30% or greater, maybe you can avoid CPAP failures by giving early rescue surfactant therapy, typically defined as within the first 1 or 2 hours. European consensus guidelines for surfactant treatment, they keep updating it every 3 years. This is the most recent update. In preterm baby, less than 32-week gestation, if the baby requires intubation for stabilization in the delivery room, FiO2 is no longer a criteria. You just go ahead and give surfactant to that baby. If the babies are requiring surfactant and animal-derived surfactant is better, LISA is the preferred method. And then laryngeal mass surfactant may be used for more mature babies over 1 kilo, because we really do not have a micro LMA, small size. Carrie Roberts from Minneapolis, she has a patent on a small laryngeal mass carrier that could be used even in babies less than 600 grams, but we do not have it available commercially. I will also show you data on SALSA, supraglottic airway surfactant administration. Again, initial dose is 200. In babies, FiO2 is more than 30, or on CPAP pressure of at least 6 centimeters or greater, or if lung ultrasound suggests surfactant need. A second or third dose may be required if there is evidence of ongoing RDS. That is higher FiO2 still, chest X-ray shows bad RDS. So in Anton Van Kamp from Netherlands wrote a review article in December last year, and they showed infants with RDS intubated and ventilated from birth benefit from prophylactic or early, less than 2 hours selective surfactant treatment. There's no clear benefit of prophylactic surfactant treatment in babies with RDS managed on nasal CPAP from birth. Again, this is a controversial topic. I showed you some data that if the babies are on CPAP and FiO2 is more than 30, data suggests that you should give it early. Again, all 3 of them were retrospective studies. Optimal timing of surfactant administered via Ensure or LISA to babies with RDS is currently unknown. It's a strong statement, in my opinion. So Ramaswamy and Christoph Rohr last year published in The Lancet, looking at systematic review and the network meta-analysis. Network meta-analysis also includes randomized controlled trials and other studies that indirect evidence. So 58 randomized control trials were included in babies less than or equal to 30 weeks gestation after adjusting for the modality of surfactant administration in AA ratio, AAPO2 ratio less than 0.36, which corresponds to an FiO2 between 37 to 55, was ranked as the best threshold for decreasing the risk of IME, mechanical ventilation, but with low certainty. Further, surfactant administration at an FiO2 of 40 to 45% possibly decreased the mortality compared to rescue treatment when respiratory failure was diagnosed. Again, certainty very low. The reasonable inference that could be drawn from these findings are just stretching and stretching. Lots of studies that surfactant administration may be considered in preterm neonates less than or equal to 30 weeks with RDS requiring an FiO2 of now they've gone back to 40% or greater. American Academy of Pediatrics Committee of the Fetus and Newborn in 2014 recommended 40% FiO2. They have not revised those guidelines. There was insufficient evidence for the comparison of FiO2 thresholds. Either 30 or 40 is better. We don't have any data. The evidence was sparse for surfactant administration guided by lung ultrasound. Again, these findings or these conclusions may not be generalizable, especially for preterm babies born at 22 to 24 weeks, because there is a very small number of babies at this gestational age in this network meta-analysis. Again, insufficient evidence comparing 30 or 40%. So this is a paper from Spain, early surfactant guided by lung ultrasound in preterm with RDS, very small study, 56 babies in less than 32 weeks. So they concluded that a lung ultrasound scored more than 8. I always tell my fellows, this is like a waterfall, Niagara waterfall. You see coalescent B lines and no CA lines, lot of interstitial fluid, edema, suggestive of surfactant deficiency. So they showed that allowed an earlier surfactant treatment, reduced oxygen exposure, better oxygenation after treatment. So this may lead to reduced oxygen exposure when they use a score of 8 or greater. Again, small number of babies. This in Connecticut, a paper published just about a month, August of this year, 2 months ago. Exactly 2 months ago. September, today is October 9th, right? Diagnostic accuracy of lung ultrasound score greater than 9 for prediction of surfactant treatment. And they used FiO2 as 30, greater than 30%, a level 4 unit. Again, small number of babies, just 30 babies. So median gestational age, 33 weeks, more mature babies. Median birth weight is 2 kilos. They concluded a lung ultrasound score more than 99 provided excellent sensitivity and specificity for predicting which infants will receive surfactant for respiratory failure. Sensitivity was 100%. When you use FiO2, 91%. So positive predictive value was 80% versus FiO2 was 100%. So again, small number of babies, both the Spain study and the single center study from Connecticut, US. So I really think we are not there yet to use lung ultrasound to predict the need for surfactant treatment. But for the time being, I think the FiO2, and it depends on how often CPAP fails in babies in your center, and the FiO2 is 30 or 35%. This is for late now. Talked about early, little bit of delayed rescue, 30 versus 40%. And now, what about late surfactant in babies with prolonged RDS? You gave surf, baby got better, but now after a week, baby's getting worse. This is a French study from level 3, 13 level 3 NICUs, 118 babies, published in 2016. Less than 33 weeks on IMB or on high frequency oscillation at 14 days of age, and the FiO2 is more than 30. Or OI, oxygen index, more than 8, equal to 8 or greater for 6 hours. Mean gestational age was 26 weeks. Mean birth weight is 800 or 770 grams. So in this randomized control trial, there was no difference in ventilation duration. There was a significant increase in rehospitalization rate for respiratory problems after discharge if you gave surfactant. After 2 weeks of age, babies with respiratory failure. So 28% of the babies got rehospitalized compared to 50%. So late surfactant administration is associated with better pulmonary outcome than controls at 1 year of age. There are a couple of observation studies, including one from Canada by Pandit et al. Many years ago, that showed that post-surfactant slump, and they gave surfactant and got improvement in compliance. What about prophylactic oropharyngeal surfactant? POPA trial, which was published this year in JAMA Pediatrics, 251 babies from 9 European countries, all of them are less than 29 weeks. So this is the conclusion and relevance of their finding, that administration of prophylactic oropharyngeal surfactant to newborn babies before 29-week gestation in the delivery room did not reduce the need for intubation in the first 120 hours of life. These findings suggest that administered surfactant in the oropharynx immediately after birth, in addition to CPAP, should not be routinely used. I think there is no data to support POPA trial. What about in neonatal ARDS or N or NOTS? There are a number of surfactant abnormalities in babies with neonatal ARDS, secondary to meconium aspiration, secondary to pneumonia, even COVID pneumonia. Number one, surfactant synthesis decreased. Number two problem is due to surfactant type 2 cell dysfunction, secretion is also has been shown to be decreased in animal models. And the small aggregate forms are not surface active. Large aggregate forms are the surface active surfactant. So after it released from type 2 cells, it forms monolayer or multi-layer. But in babies with lung injury and ARDS, they have catabolic form of surfactant called the small aggregate surfactants are higher. And fourth issue is the serum proteins or blood in the alveolar space also has been shown to inactivate surfactant. So these are the reasons and the babies have ABCA3 mutation. These are the reasons why in babies with acute RDS, I'm talking about late preterm or term babies with respiratory failure, surfactant treatment may be an option. Here, let's talk about the pulmonary hemorrhage, because blood can inactivate, or fibrinogen or albumin can inactivate surfactant. Again, this is the study from Pandit in Canada. Small number of babies, 1995. 15 babies, they showed the decrease in OI and increase in AAPO2 ratio after giving surfactant. They used Owen surfactant. So exogenous surfactant treatment appears to be an adjunctive useful therapy in a clinically significant pulmonary hemorrhage and hypoxemic respiratory failure. A second study, again, small number of studies from Taipei, they showed they used intratracheal spraying of epinephrine 1 in 10,000, 0.5 ml diluted with 1 ml of air, and then they sprayed it via the ET tube. These babies are on oscillation, high frequency ventilation, corrected the DIC, surfactant was given within half an hour to 1.5 hours post pulmonary hemorrhage. And they showed that AAPO2 improved significantly, and time to reach FiO2 less than 40% was 13 hours compared to 41 hours without surfactant treatment. Again, not a randomized control trial, observational study. The only randomized control trial done in neonatal ARDS, secondary to meconium aspiration, was published from Santiago, Chile in 2020. So the 100 babies were enrolled. Majority of them were due to meconium aspiration syndrome, and they used poractant alpha 100 milligram per kilo plus nitric oxide. These are all babies had echocardiographic documented pulmonary hypertension and OI more than 20. So this is 38 or 39 week gestation. The control group, they just gave nitric oxide. In the treatment arm, they gave surfactant and then followed with nitric oxide. And the baseline OI was quite bad, 38 and 37, range up to 77 or 67. These babies would end up on ECMO. Second dose of Curosur, if OI was more than 20, 6 to 12 hours after the first dose. Here is the control population that got only nitric oxide. Here is surfactant plus nitric. You can see the significant decrease in OI, and the need for ECMO or death was lower, 16% versus 36%. So clearly in ARDS babies or meconium aspiration and acute RDS hypoxemic respiratory failure, giving surfactant tends to decrease the need for ECMO or death. Again, Dr. Satyan and Ganesh Ganduri We've done a lot of studies on PPHN and hypoxemic respiratory failure, wrote a commentary about this paper and said this approach should now be the standard practice for newborn babies with hypoxemic respiratory failure and PPHN due to parenchymal lung disease. The baby has clear lungs or hypoplastic lung. Surfactant therapy is not indicated, just like diaphragmatic hernia babies. So what is the expanded indications? Pulmonary hemorrhage, ARDS, secondary meconium aspiration, congenital pneumonia, or sepsis-induced ARDS, air leak syndrome due to severe surfactant deficiency or dysfunction, like SPB deficiency or SPC deficiency, congenital diaphragmatic hernia, no. What do we use? What to use? I think we prefer poractant alpha because smaller volume. And there are studies that showed that it has a positive effect on bacterial killing and increased DPPC and SPB. And how do we use it? We generally recommend using it as a bolus. And the dose is anywhere from 50 to 100 milligram per kilo dose. Sometimes we have to give a second dose after 6 or 12 hours. Now, let's go to the technique. The last part is, we went from invasive endotracheal tube and surfactant and keeping the baby intubated to insure or inrexure, which is intubation, recruit the lung with high frequency ventilation, surfactant, and then extubation. LISA or mist, they basically mean the same, using a smaller catheter other than an endotracheal tube. So feeding tube, umbilical arterial catheter, or angio catheter like we do here. And then LMA or SALSA, pharyngeal installation, no good. I showed you already data. Nebulization or atomization is truly non-invasive surfactant treatment or NIST. However, none of the studies have shown in babies less than 29 weeks, nebulization works. So it works in bigger babies, late preterm babies, you can use that, but not in micro preemies. So insure versus LISA, both of them require laryngoscopy. You need to look at it. It's not a blind intubation or blind passage of a catheter. Need for positive pressure ventilation is yes after insure, whereas it basically relies on baby spontaneous breathing. You need an ET tube. You can use a thin catheter, as I mentioned. Any one of them is fine. Secure airway, yes, you have well control. Here must be careful with LISA technique because the catheter may slip out. You don't have a good control. You want to make sure the LISA catheter or an angio catheter is in the trachea, but there are a number of ways to verify that. Vocal cords are abducted, whereas vocal cords can adduct. Babies can breathe spontaneously. Sedative medications are often used. This is an elective intubation, so nobody wants to intubate a baby without, a sedation, mainly often used. Whereas here, even though it's awake intubation, many people are not using routinely sedation. Again, it's a controversial topic. Tolerability, yeah, babies over 30 weeks tolerate well. Extremely low gestation babies, LISA are missed. Surfactant kinetics, there's a study published by Kajsa Bolin from Stockholm, where they looked at lung association of surfactant is less with insure technique, and dynamic compliance also lower. Whereas if the LISA in this rabbit model, they showed better distribution of surfactant and improved dynamic compliance. There's another study from Amsterdam where they looked at small number of babies, but they used electrical impedance tomography to measure the end expiratory lung volume and SF ratio, saturation to FiO2 ratio in preterm babies, 26 to 36 weeks. On CPAP, the FiO2 was 30 or greater. It's an observation study. This is before end expiratory lung volume. They used a LISA using umbilical catheter. They gave Curosep, just took one vial and gave it 160 to 240 milligrams per kilo. They gave it over 1 to 3 minutes. However, they kept it under direct visualization of the vocal cords, which is not a good idea. If you're going to go LISA, once you put the catheter in, you want to close the mouth so that the baby can receive CPAP or NIPPV. However, even in spite of that, they were able to show that end expiratory lung volume within 5 minutes post-surfactant significantly improved, and 30 minutes and 60 minutes. SF ratio, saturation to FiO2 ratio also improved after 5 minutes and then stayed higher. So after LISA, they kept the baby 12 degrees elevated in the reverse Mandela question. What about trials comparing Lisa with Ensure? 16 trials, over 2,000 babies in this Cochrane review. Need for intubation within first 72 hours was significantly lower. Number needed to treat is 8 babies, 95 confidence interval 6 to 14 babies if you give surfactant by a Lisa method compared to Ensure. They also looked at BPD, effect of BPD. Number needed to treat is 14 babies. Confidence interval is still narrow, pretty narrow, 9 to 25 babies. They also looked at composite outcome of effect of death or BPD in the same 16 trials. Number needed to benefit is 9, 6 to 14 babies. I think clearly randomized control trials have shown that giving surfactant by a Lisa technique is much, much better than Ensure technique. I don't think it's a controversy anymore. So how do we optimize Lisa? This is a paper from Dallas. This is a quality improvement project called the OptiSurf, Optimizing Surfactant Bundle. So they started the baby on CPAP of 5, transferred to the NICU. The FiO2 was more than 30. They increased the CPAP to 6, and then put lines in, and then watch the baby for 30 minutes. Still the FiO2 is more than 30. They went up to CPAP of 7. And then they gave surfactant using Lisa technique. So basically, they increased CPAP from 5 to 7. This was published in 2021. I think nowadays, even though we don't know what the optimal CPAP pressure in preterm babies is, everybody is using 6 or 7. I don't know what you do in Canada. I would love to hear your thoughts on that. Again, FiO2 threshold of 0.7 and 0.3. So they show that CPAP failures were 45%. By optimizing the CPAP pressure and then giving early surfactant, the FiO2 was more than 30, they were able to reduce the CPAP failure to 11%. So pretty good number. Again, a QI project. A similar paper from Cleveland Rainbow Babies Children's in Cleveland. So they never used Lisa. They were 0% before they started the QI, and their goal was to go up to 45%. And they reached that goal. Median use of Lisa in that NICU went from 0 to 45%. And they showed that complications of Lisa, reflux of surfactant 25%, desaturations less than 60% happened in 17%, apnea 14%, cough 3%, intubation within 24 hours 5%. So they also looked at no BPD, again, small number, observational QI project. So their plans are, based on this finding, they're expanded to all gestational age using Lisa, including 23 weeks, in the delivery room as part of the resuscitation. It's a paper published from Anne Greener's group in London, looking at use of Lisa in the delivery room using Lisa catheter and outcomes. So they show that cost of Lisa treatment in preterm babies in the DR with less need for mechanical ventilation and cost of care, but less successful in those with initial more severe RDS. So it works in babies with mild to moderate RDS. FiO2 was 60% here. Post Lisa dropped to 27%. SF ratio also improved. So cost of NICU care with Lisa was 2,436 pounds compared to 6,000 pounds with the Ensure technique. And total cost of stay was also 13,000 pounds compared to 25,000 pounds. So in mild to moderate RDS, early delivery room Lisa appears to be better. But again, we need more studies. So these are some of the largest randomized control trials. We were part of this Peter Dargwell's trial, the Optimus trial, 25 to 28 week gestation. This is comparing Lisa versus CPAP, no surfactant. This took a long time, and then COVID came, so the study was stopped after 485 babies were enrolled out of the original samples of 606. So BPD among survivors was less, 37.3 compared to 45.3%. But as a primary outcome was death or BPD, as a composite outcome was no different, even though 6% less. They also reported In this study, we also reported spontaneous intestinal perforation or focal intestinal perforation was 1.7% versus 2.5%. The rest of them, pneumothorax requiring chest tube was lower, 4.6 versus 10%. Need for intubation within 72 hours of age was also lower, 36, almost half, 72%. And major morbidity in the first hospital among survivors was lower, p-value 0.05. The only thing that was concerning in this study, death prior to 36 post-menstrual age was 2.2% higher, 10% versus 7.8%. There are a lot of discussion, back-to-back editorial comments from the authors, Peter and others. It happened that multiple gestation was more in the LISA group or MIST group, and the birth weight was also smaller in that group, which so happened. Death during hospitalization, 11.6 versus 8.2, even though not statistically significant. People are worried about it. There is a follow-up study published last year. We had 453 out of the 486 babies available for follow-up, and death or neurodermal disability was no different. Secondary outcomes, hospitalization with respiratory illness was significantly lower in the LISA or MIST group. So conclusions and relevance in this follow-up study of a randomized controlled trial, treatment with using MIST technique compared to the sham treatment did not reduce the incidence of death or neurodermal disability. However, infants who received MIST had a lower rates of adverse respiratory outcomes in their first 2 years of life, getting admitted, staying on bronchodilators or oxygen therapy were the outcomes that were looked at. This is from Canada, looking at real-world clinical impact of adopting LISA using video laryngoscopy 90% of the time in extremely preterm babies, 24 to 28-week gestation, pre and post cohort study, and they concluded that systematic and comprehensive evaluative data from this large Canadian neonatal network supports in favor of LISA compared to endotracheal tube. And they recommend substantiate LISA as the standard of care for surfactant administration whenever feasible for babies between from 24 to 28 weeks gestation. Another paper from Germany Neonatal Network. They also have a huge number of database, LISA, and complications of prematurity in a cohort study of very low birth weight infants. 2,624 babies on LISA, Ensure 3,695. You can see birth weight was a little bigger, 884, about 70 grams. Gestational age, 0.6 weeks more mature in the LISA group. Mortality was lower, BPD was lower, IBH grade 2 to 3, 4 was lower, ROP requiring surgery was also lower. So all of them are in favor of LISA. However, focal intestinal perforation was high, 1.49 odds ratio. Again, we really don't have a good explanation as to why surfactant treatment results in LISA technique results in more focal intestinal perforation. Again, it was limited to babies less than 26 weeks, 10% with LISA, 7.4% with endotracheal tube surfactant administration. So here is another paper looking at quasi-prophylactically given in the delivery room. 83% of them received LISA with no FiO2 criteria. And now they included 22 weeks babies. And they showed from, again, 25 weeks, 0.2 weeks difference. Birth weight is less than 40 grams. IMB, less than 7 days of age, was 52% compared to 100%. Stay intubated, pneumothorax was low, death in the hospital, all-cause mortality was low, BPD was lower. So this long-term multi-center cohort study suggests that LISA may be associated with reduced risk of adverse outcomes in extremely preterm infants. You can see where I'm going with all this data. So that's, I think LISA appears to be the best in baby that requires surfactant. Now, last few minutes about LMA. This one is about MIST in bigger babies. So they used Biractant alpha, Quebec, Canada, under direct supervision. So it showed that need for mechanical ventilation or pneumothorax needing chest tube was much lower. Surprised that 90% of the babies, not all of them got pneumothorax, but intubated. Small, random, again, more mature babies, 32 to 36 weeks. They did find surfactant reflux was high, 66%. I think it's likely due to, number one, large volume. Number two, they kept the mouth open during this procedure. What about sedation? These are our guidelines we use in our unit. We use in babies between 23 to 26 weeks gestation, atropine, 20 mics per kilo, 4 minutes before, and then we use oral sucrose, 0.4 ml. The peak effect lasts for 4 to 8 minutes. In bigger babies, we still, again, atropine plus oral sucrose. But if the baby is very active, we sometimes use fentanyl, 1 mic per kilo per dose, 3 minutes before, given slowly, and we always keep naloxone at the bedside. There is a study called NONA study, non-invasive, NONA-LISA, non-invasive, non-pharmacological, no sedation during LISA, and that protocol has been published from Denmark, and they don't have that many babies in Denmark, so they are trying to expand the NONA-LISA study to other centers. So if you know somebody in Denmark interested, you may want to participate in that study. What about verification of the angiocatheter using ultrasound? So we use a hockey stick. We call Ultra LISA, ultrasound guided LISA. This is my fellow, my therapist, nurse, attending, trying to help. So we were able to show that you can actually see the LISA catheter. You can also see the surfactant going down. Another easy way to verify. I'm going to skip the video. Oops. So here is the trachea, cartilage, reverberations. There's the OG tube here. And here is surfactant catheter. And when you give surfactant, you can see surfactant going down. So we submitted this paper, got revised and resubmitted. Hopefully it'll get accepted in Journal of Perinatology. Again, you use lung ultrasound a lot. You have the ultrasound probe. If you want to stick it in, if you're in doubt, see where the catheter is and whether surfactant is going down the trachea or not. So there are problems with LISA, but there are solutions. Bradycardian desaturation, you can do atropine or fentanyl. Propofol is neurotoxic, but in European countries, a lot of them use propofol in preterm babies during LISA. Apnea, and we use caffeine before the LISA procedure, which is becoming a standard of practice. Ketamine also used in some centers, but that has been actually shown to increase the apnea risk. So we do not use ketamine. On failure of first attempt, sedating the baby has been shown to decrease the failure rate in some studies. How far do you go? 1.5 centimeters for babies less than 27 weeks, 2 centimeters for all other babies. That's what the Melman group does. Again, dislodgement of the catheter, you can visualize. I don't recommend using the laryngoscope while you are giving surfactant by LISA technique because you lose the benefit of positive pressure. Baby is coughing and gagging, give it slowly over 2 to 3 minutes. You don't have to rush. Reflux, using a small caliber catheter like a LISA catheter or an angio catheter, and slow down 0.5 to 1 ml per minute is a reasonable. Even if the micropremi they don't tolerate, just slow down. Maybe give it over 2 or 3 minutes. Reflux, give small volume surfactant, reverse Trendelenburg, and repeat LISA procedure. If you use a higher dose, likely you don't have to give a second dose. And improving post-LISA success, I think NIPPV pre and post-LISA has been shown to improve the success rate. So I think LISA is here to stay. It's no longer a fashion. What about in rescue? Intubate surfactant, recruit the lung on an oscillator, and then give surfactant. They said this reduced the need for mechanical ventilation in the first 72 hours of life, might facilitate implementation of a non-invasive respiratory support strategy. My question is, I do not believe that it's really a non-invasive. You're intubating the baby, putting them on an oscillator, recruiting the lung. That's pretty invasive. So SALSA technique, supraglottic airway, Studies have been done only in bigger babies. This is 28 to 35 weeks. Even with these bigger babies, LMA seems to work. So in lower and middle income countries or in a level 2 unit, people don't have much experience with intubation. This may be a good technique, but again, over 28 weeks. Even with Lisa LMA technique, there's a lot of surfactant reflux. They got 50% of surfactant they aspirate from the stomach. This is Carrie Roberts' study. It's a multi-center study. So there have been supraglottic air device versus CPAP, 4 randomized controlled trials, and 4 of them LMA versus Ensure technique has been published. And again, all of them are in bigger babies, over 1250 or over 28-week gestation. So this is a Cochrane database review published January of this year. They showed that surfactant via LMA use should be limited to clinical trials in babies less than 32 weeks. What about surfactant plus budesonide plus trial? Preventing lung disease using surfactant and steroids. Largest multi-center randomized controlled trial, over 1,000 babies. Okay, unfortunately, all babies less than 28-week gestation at less than 48 hours of hold. This was a very disappointing result. Small randomized controlled trials, 3 of them showed before dramatic improvement, combining surfactant with budesonide. This study, survival-free of BPD, absolutely no difference. Alive at 36 weeks, no difference. Very disappointing study for the investigators and everybody that participated in the trial. This was yet to be published, but data was presented at the 2024 conference, Toronto. There is another large randomized multi-center trial in the United States called the budesonide in babies plus surfactant. BIB study is ongoing. Sample size is 1160, and study is expected to be ending in September 2027. So we have to wait for the results before we combine surfactant with budesonide. Many centers, they were doing that, but now they stopped in the US. So there was an RDS neonatal expert, RDS Next consensus statement for use of surfactant for RDS published last year. Vineet Pandari was the lead on this surfactant indicator table. They came out with these criteria, at least 3 of the 4 criteria. Babies 23 to 27 week gestation, if you're using a Downer score, 4 to 7. Respiratory support, intubate anytime or on NIPPV, mean airway pressure more than 6, or CPAP at least 6 centimeters or greater. In more mature baby, they use 7 centimeters. FiO2 more than 30, more than 40 if it is beyond 2 hours of life, and same criteria in both groups. And so 3 of the 4 criteria have been met. Or baby has respiratory acidosis, then you should consider giving surfactant. So I think, last slide, in summary, based on evidence, time has come for a lower FiO2 threshold. I put a question mark. Clearly for Lisa technique, I think the data is very solid. And based on evidence, poractant alpha higher dose may be better, especially in smaller babies. And technique is Lisa. Thank you very much for listening. We'll be happy to answer any questions you may have.
Thanks a lot, Dr. Ram, for this wonderful presentation, And I'm opening the floor for any question from the attendees. So I understand that there were multiple comparisons between poractant and the other surfactant, but have they compared the same concentration? Because I believe that the poractant usually it is 200 milligram per kilo per dose, although the one for Bliss or the other ones will be, I think, at 100 or 150, depends on the formula. So
yeah. The Lemry study from Canada, she compared 200 of poractant alpha versus 135 of Bliss. That's the only study. That's again a pragmatic study. There was a randomized control trial, a small study that showed that poractantol was better. Again, that's 200 versus 135. So there are no studies comparing similar dosage between BLESS and poractant alpha. The only comparison was between poractant alpha and piractant or Surfactant, 200 or 100.
And what is the evidence for surfactant use in meconium aspiration syndrome?
That is the first randomized control trial. People were using it anecdotally in published observation studies. In fact, in 99 or 98, Richard Finley from Los Angeles published a randomized control trial. That time they used Surfactant in those babies with meconium aspiration. It's a huge volume, 4 ml per kilo, bigger babies. They did not see any response up to 2 doses after they gave a third dose every 6 hours. That's 300 milligram per kilo dose. They showed an improvement and less need for ECMO or death. And this is the first randomized control trial, 100 babies, that study I just showed you. Lavaging the meconium aspiration, I don't think anybody's doing that. It's pretty, babies don't tolerate lung lavage and then giving surfactant. So most people would, suction if there is any meconium and then just give it as a bolus.
And I believe you mentioned about like late use of surfactant, I think after 2 weeks. But is there really a clinical use for it in like BPD or like the babies who are like lung with like severe PIE and they're on the ventilator for a long time? We tried steroids. Is there any role for trying surfactant for such population?
Yeah, I mean this study from French neonatal units were done in after 2 weeks of age, and the baby still requires higher FiO2 or higher oxygenation index. In our center, in my recommendation is, babies are getting to 10 to 14 days old, they're starting to develop hazy lungs, post surfactant slump or got the leaks. Surfactant gets inactivated, and I'm thinking about using dexamethasone. Now, what I do, I give surfactant to the baby and see if the baby gets better. If the compliance improves, I try to extubate the baby. If I gave surfactant, baby's not getting better, then I would do Dex. So I'm trying to reduce the dexamethasone use as much as possible. And surfactant, other than expense, it's pretty safe drug. And therefore, I would suggest give a dose of surfactant. We actually have a baby now in our unit here at Cedars. I recommended to my team that maybe we should give surf, and then that doesn't work, DART. In fact, this baby actually was started on DART day 3 and hasn't had much improvement. I said, okay, here's a 2.5 ET2. Let's surf the baby, extubate the baby to NIPPB.
Oh, so you would put the surfactant as one step before considering steroids for such population.
Yeah, I'm trying to minimize the postnatal DEX use as much as possible.
Yeah.
Even though if you use DEX after 2 weeks, it doesn't appear to affect neurodevelopmental outcome. And now they are saying cumulative dose of 4 milligrams of dexamethasone is better than 0.89, like the DART protocol. So we keep getting, that's another huge controversial topic about steroids, hydrocortisone or DEX. I think Dex is better than hydrocortisone, but hydrocortisone is safer. Doesn't work well as good as Dex.
So any question for the attendees from the attendees?
So what is the Canadian practice in Canada? You use FiO2 30% or 40%? One question.
I think usually we would be using 30%, and the centers probably has different approach. So for our center, as you know, you probably know, and also in presence of Yasser, we are implementing the lung ultrasound to a high extent in the decision of like giving surfactant, which I believe no many centers are doing this, although the number is increasing, especially as you mentioned with Daniel De Luca from Paris, who's like advocating for this approach. And there is evolving great evidence about this. So I think it is working, looks it was working fine, like depending on the lung ultrasound score. And sometimes also some people will be adding the current FI2 that the baby requires as well.
Yeah.
And we would be targeting probably CPAP reaching PEEP of 7 also before like deciding for the next step of surfactant.
Okay.
Yeah. So we really enjoyed having you today. Hopefully that this presentation or different one would be repeated soon. Thanks a lot for being here, and we are really happy to have you. Thank you.
Thank you so much and have a blessed day. Okay.
Thank you as well. Bye.
Bye.
Take care.